Well, good evening, everyone. Welcome to the New Mexico Kidney Foundation. I think this is our third monthly kidney talk. We really appreciate the participation of everyone who's joined us these past few months. Today we have the pleasure of having Catherine Soller joining us to talk about medications for type 2 diabetes. Catherine is the lead clinician at Sage Specialty Care, which is the largest private endocrinology clinic in New Mexico.
Talk about medications for type 2 diabetes.
So you may have to go ahead and mute your microphone. Anyway, she's with Sage Specialty Care, and that's the largest endocrinology clinic in New Mexico with over 25 years of medical experience and 10 years specializing in diabetes and endocrinology as a board certified nurse practitioner. She also has her Master's of Science in Nursing from Oakland University, where she was the Hartford Scholar. She's certified as an adult nurse practitioner, a geriatric specialist, and board certified in adult and geriatrics, and is a certified diabetes educator. So I think we have some excellent credentials there to share with us with regards to medications, diabetes, and in looking at her presentation, the effects on kidneys, which is our focus here this evening. So with that, I'd like to go ahead and turn it over to Catherine and welcome you very closely. And before I do that, let me just remind everyone that New Mexico Kidney Foundation, we're here to serve the people of New Mexico. If you're interested in learning more about how you can help us in our effort to eliminate kidney disease, please go to our website at nmkidney.org. That's NM as in New Mexico, kidney.org. And there you can find lots of information. There's a page you can go to where we have opportunities for you to assist us with donations or with volunteering. So please take a look at that page as well. So now with that, Catherine, let me turn it over to you.
Well, thank you, Tim. And as you said, my name's Catherine. I go by Kathy, and I have the pleasure of talking about medications for type 2 diabetes tonight. We have, I want to start just by saying type 2 diabetes is a lot different disease than type 1 diabetes. In type 2 diabetes, the body still makes insulin, but it can't use it properly. The official term for this is known as insulin resistance. So as we look at all the different medications there are for type 2 diabetes, each group of medications target different organs in the body and work differently. So the liver and pancreas, those medications are a group that includes Januvia, Tradjenta, Onglyza. They help the pancreas make more insulin, and they also reduce the amount of glucose made by the liver. The medications that work on the pancreas, this group, some of these are older medications and we don't use them very much. The glimepiride and glipizides are the ones most frequently used. They actually help the pancreas produce more insulin. The intestines have a couple of medications, acarbose and miglatol, and they help break down carbohydrates, and as they break them down, they lower your blood glucose. A few years back, we added a group of medications that works through the kidneys. Those are Invokana, Jardiance, Farxiga, and Steglatro, and they help by preventing the kidneys from holding on to the glucose. The kidneys release the glucose instead of recycling it kind of back in. And then the liver, fat tissue and muscles, that group is the metformin, pioglitazone. They lower glucose by reducing the amount of glucose made by the liver and also increasing that sensitivity to insulin, fat, liver, and muscle cells. So that really targets that insulin sensitivity. The actual classes of medications and their names, we'll go through each one individually and talk about each one. Some of these are, like I said, a lot older drugs, and we don't use them as often, but we do use them for different things depending on what else is going on with each individual person. So the alpha glucosidase inhibitors, they are known as the starch blockers. That's the acarbose and miglitol, and they block the breakdown of the starchy foods in your digestive system. So by blocking the breakdown of these starches, including bread, potatoes, pastas by the intestines, they also slow the breakdown of the sugars, such as table sugars, and this keeps it from having a rise in your sugar after a meal. They should be taken at the very beginning of a meal. Unfortunately, they do have the side effects pretty frequently of gas and diarrhea because we're not breaking down those starches. And bloating, that's one of the real big side effects of this. These drugs are safe for kidneys up through stage 4 kidney disease. And with that, we look at that GFR greater than 25. And then we have the biguanides, which metformin is the real lead in this group. And that lowers the production of glucose through the liver and makes the muscle cells more sensitive to the insulin. It allows the muscle cells to take up the glucose into the cells. So it's pulling it out of the cell into the muscle where it belongs so that the insulin can take care of it. A big effect is how it helps the liver to work properly. In diabetes, a lot of organs are getting the wrong signal. And so the liver isn't really saying, hey, there's plenty of sugar in the bloodstream here, I don't need to produce more. Unfortunately, it starts producing even more sugar, dumping it into the bloodstream, making your sugar go up. And what metformin does is it tells the liver, hey, let's look at this differently. There's lots of sugar here. We don't need to create even more. Metformin, a lot of times you have to take it 2 times a day. You take it with meals. There's also an extended release that you only have to take once a day. The big effects with metformin are the stomach problems, the GI problems. Diarrhea is one of the big ones. Taking it with food or sometimes taking the extended release version can really alleviate that. It also helps with metformin if we titrate it slowly. So you start with 1 pill a day for a week, and then you go to 2 pills a day for a week. And by building it up slowly like that, a lot of people don't experience the side effects on their gut. Metformin is safe when you have kidney disease, but we do have to watch the level of the kidney function and adjust the dose of metformin to match it. This next group is not used very frequently, but sometimes it's helpful, again, with certain groups of people. It's the trade name is called Welchol. It's not a real big, powerful lowering blood glucose lowering medication, but it does help. It helps, number one, it removes the cholesterol from the body. So if we get a little side benefit of lowering your sugar too, sometimes that makes that a good medication to choose to use. We don't need to go with all the technicalities, but because it is a cholesterol medicine, it's binding and lowering the cholesterol at the same time. And so because it's not absorbed into the bloodstream, they're usually pretty safe for people who have liver problems. And like I said, so sometimes we can add these other medications in to help. But again, like that other group we talked about at the beginning, we've got the flatulence, but instead of diarrhea, this group of medicine causes constipation. So again, not everyone can take this one. The effects on the kidneys are pretty mild. We can use it down to at least moderate kidney disease. So we're looking at a GFR above 30. And one of the reasons for that is not because it's not safe, but just because it's really never been studied in lower kidney function. One of the not very new, but more modern medications are the group we call the DPP-4 inhibitors. That is allogliptin, linagliptin, saxagliptin, and sitagliptin. So those are their generic names. They work by they slow the breakdown of the hormone GLP-1. That helps the insulin stay around your system longer, which then has the side effect of lowering your blood glucose. And another nice side effect of this is it decreases your appetite. The trade names for these are Januvia, Nesina, Onglyza, and Tradjenta. What's really nice about this class of drug is really rare that they cause any hypoglycemia or low sugars. So they prevent that breakdown of that GLP-1, and that keeps the insulin hanging around. And because it's a slow process, we don't get the hypoglycemia with it. And I like to think of this group of medications as being sugar specific. They work when the sugar's high, they don't work when the sugar's low. Side effects are kind of varied. They're not very severe. They say flu-like symptoms, but usually people will say, boy, I've had kind of a stuffy nose or a runny nose since I started this medication. Rarely you can have some gastrointestinal problems, some nausea, diarrhea, but again, it doesn't happen very often. And they tend to not cause any weight gain. We call this class weight neutral. And of course, with type 2 diabetes, we don't want any medications that can cause weight gain. We like, of course, medications that help with weight loss as a side effect. This group is kind of split on their effect of the kidneys. 3 of them, the Januvia, Nesina, and Onglyza, do have to have their dose decreased to match the kidney function decline. Tradjenta is different. It does not work through the kidneys. It's not excreted through the kidneys, and therefore it never needs a dose adjustment. So I don't want to say any drugs are my favorite, but if I have to have one that I don't need to change the dose, it's always easier. And I think it's easier for everyone to remember and not worry about having dose changes. The next group, this is a newer medication. It's been around maybe a little more than 10 years. And they're the GLP-1 inhibitors. So the DPP-4s, they keep the GLP-1 from breaking down. This group of medications actually puts the GLP-1 hormone back into you. That hormone decreases in people with type 2 diabetes. They work on a couple of different ways, and they've got some really nice side effects. Number one, they decrease your appetite, decreases your food intake. causes some weight loss. Hooray, we always are happy with that. And then looking back at the beginning, it improves your insulin sensitivity. It improves the beta cell function. Beta cells are the cells in the pancreas that actually make the insulin. So if we can improve that, that's a great side effect. It improves insulin secretion. It decreases glucagon. That's that sugar that is produced by the liver. And it decreases gastric emptying, and that means it slows the digestion through the system, so it makes you feel full longer, thus decreasing your appetite. The side effects that we get from this is we get a really nice lowering of your hemoglobin A1C, your fasting sugars come down, and postprandial, those are your after meal sugars, those also are improved. So this category of medication has really taken off because of all these good side effects with it. Of this class, there is one that's a pill, and that is been out for maybe a year and a half, maybe 2 years. It's called Ribelsis. It's taken once daily in the morning. The others are all injectables, and the injections have really improved through the years. Most of them are once a week. That includes Bydureon, Ozempic, and Trulicity. And then Victoza is once a day, and Byetta, which was the first one that came out, is twice a day. So, of course, the once a week becomes very, very easy, very popular, since they all work quite well. So the GLP-1 is that hormone I talked about, and it's normally produced in the small intestine. It stimulates insulin secretion. So we want the insulin to be released at the right time when we need it. Like we talked about, we want it to be specific to when your sugar is high. And this category of drug does that. It inhibits, so it prevents that glucagon, that sugar, from the liver from being produced. And the two actions together really do a great job of lowering your blood sugar levels. And then it slows your stomach emptying, so less glucose is released into the bloodstream at one time. So that slow release into the bloodstream has such a good benefit of just slowly having your sugars go up, so the medications have a chance to really work for you. And then the GLP-1s really help make you feel full, so it really helps with weight loss. The side effects of this category of drugs are the gastrointestinal again. And the main one with this one, it can vary, but the big one is nausea. And just like I said about the metformin, that we slowly increase the dose so you can tolerate it, we do the same thing with this group of drugs. We start you on low doses, some of them a couple months before we start increasing the dose. Get your system used to having this hormone back in your bloodstream that hasn't been there for a while. And then people tend to tolerate them quite well. The big bonus for me for this category of drugs is it is safe to use with all levels of kidney function. You don't need to decrease the dose. There's never a point you have to stop it. Makes it really, really helpful. What we love to be able to do with kidney disease is, as a diabetic provider, I don't want people to have to go to insulin. And in the past, it was your kidneys start going down, we have to put you on insulin. Now we are starting to have a lot more medications that we can continue to use safely with the kidney function. This group of drugs, the big one that we use with this one are the sulfonylureas, and they actually stimulate your pancreas to make more insulin. The meglitides, they help you make insulin only after meals, so it lowers your glucose after eating and decreases your hypoglycemia, your low sugar risk. Unfortunately, medications need to be easier than this. Having to take a pill before every meal gets pretty difficult, and we don't get a lot of good compliance with that. And the names of these drugs, the nitiglitide, which is Starlex, and rapiglinide, which is Prandin, are in this group. And like I said, you have to take them before each meal to really have a good effect. But unfortunately, because they stimulate the release of insulin, they actually have a pretty high risk of hypoglycemia, the low blood sugar. The other real negative side effect for me is they all cause weight gain. We, again, have that stuffy nose, kind of cold or flu-like symptoms, sometimes some diarrhea. They are safe to use in kidney disease, even with renal failure, dialysis. So they sometimes do have a place if people tolerate them. And it's good to have a variety of medications available to us, but again, we're usually looking to not have the negative side effects of the low sugar and the weight gain anytime we possibly can. And again, in that category is the sulfonylureas. These are the ones we use much more often. It's glimepiride, glipizide, and glyburide. We don't even use the trade names anymore. In this group, they've been around forever, and these generics are what they really go by. A lot of them now are just 1 or 2 times a day, and you don't have to take them specifically before meals anymore. We have a lot of the extended release versions of these. They all work about the same, have about the same effect on blood sugar levels, but unfortunately, these are non-specific medications in how they work with glucose. So they stimulate the pancreas to make more insulin 24 hours a day. They're non-specific. They produce more insulin. They don't care if your sugar's 60, they're still going to make more insulin. They are just very non-specific, that they're constantly telling the pancreas, hey, let's make some more insulin here. So people have to eat. They have to eat meals on a regular basis, or they'll experience low sugars in between. So therefore, they increase your hunger. Therefore, they increase weight gain. We see a lot of weight gain with these medications. Rarely they'll give you an upset stomach. It's not very often. For me, the big ones of the weight gain and the low blood sugar makes me pretty cautious using this group. On the other hand, this category is very safe to use with kidney disease, even with complete renal failure and dialysis. So again, at low doses, sometimes they can be quite safe, and people don't have the low blood sugar, and because they're safe to use with the decreased kidney function, it makes it nice. We still have a medication we can use on people where we don't have to switch them over to insulin. I have nothing against insulin, but anytime I can use a pill instead of insulin, I'm always going to go that way. Another new group of medication, this is one of our newest groups. They've been out for about 7 or 8 years. Their big category are the SGLT2 inhibitors. They work on the kidneys by getting rid of extra glucose by peeing it out. Bluntly, that's how they work. So the glucose in your blood passes through your kidneys at a point where it can either be excreted, peed out, or reabsorbed. And unfortunately, in people with type 2 diabetes, until your sugar gets around 240, the kidneys choose not to release it. The kidneys hold it and reabsorb it back into the bloodstream, which is very hard on the kidneys. This SGLT2, technically sodium glucose transporter 2s, they work in the kidney to inhibit this. They block this action, which kind of plugs up those little holes and says, hey, or those holes that are plugged up, open up, releases this glucose in the urine. The category in these, we have Invokana, Farxiga, Jardiance, and Stiglatro. And we don't have any generics in this group yet. Their negative side effects cause increased urination. Yeast infections are a big one, especially if you're not drinking enough water. And the same thing if your sugar is too concentrated in your urine, or your urine's too concentrated with sugar, urinary tract infections. You need to drink a lot of water to keep that diluted when you're on this medication. But a great side effect of this class is the weight loss. So when you're releasing sugar in the urine, you're also releasing calories. So that's a real nice side benefit. Because of a lot of different technicalities and how this medication works through the kidneys, we found that they actually protect the kidneys from diabetic kidney disease. And it's safe to use most of them, not all of them. Each one has a different specific number, but most of them can be used all the way to stage 4 kidney disease. So this group of drugs is one of my favorites because I love the idea that we can offer the kidneys some protection. Another one of the older medications, the we're not going to say that. The TZDs, that's what these are known as. And of this class, there's 2, pioglitazone and rosiglitazone. Rosiglitazone has had some unfortunate heart side effects, and it's been pulled off the market. So we really just have the pioglitazone now. This category actually works really well in the liver, and it kind of like the metformin does, helps to make the cells more sensitive to insulin, and it helps to increase the amount of sugar that muscles and fat cells take from the bloodstream. They help the insulin to work better. They also greatly reduce glucose production from the liver. This pioglitazone, which is actose, can significantly improve the performance of the liver and is often used for fatty liver disease. So if somebody has diabetes and fatty liver disease, even at very low doses, this medication can really help the liver. Unfortunately, it has some significant side effects. Not always. It can cause swelling, which can lead to heart failure. So somebody who is at risk for heart failure, we wouldn't use this medication. It does cause some weight gain. It can cause bone fractures at the higher doses. And a few years back, we discovered that the 45 milligram dose is associated with bladder cancer, but not the 2 lower doses. This medication is always a keeper as long as we can, we don't have the other side effects to worry about, because it is also safe to use with kidney disease. That wraps up my slideshow, and my talk of all the different kind of medications. And so I welcome questions.
Well, excellent. I just hearing all that, it's like it's a lot of wonderful information, and I love the way you presented it and showing the effects and the impacts, on the kidney generally with each medication, each family of medications, and then also specifically, our interest, obviously, with regards to kidneys. So I really appreciate that. And while I just said if anyone has any questions, they're welcome to write them here in the chat. While they're doing so, Kathy, I'm just kind of wondering, so if these different families, I mean, obviously it depends on, each individual. If a person who has diabetes and is concerned about, kidney disease or, wants to protect, can they talk about these different medications, or is that really just a function of their primary care physician knowing about these? And so, yeah, how does one approach that if they have diabetes?
Well, I think it's a great thing for people to have the knowledge. And that's why I tried to make it basic enough that you can say, hey, I have kidney disease. I wonder if this is a good medication for me. Or I could stand to lose a little weight. Maybe this category of drug would be a good one for me to try. But really, the doctor needs to be able to pull it all together and look at each individual and say, which medication gives us the best kind of bang for our buck? What's going to do a lot of different things so somebody doesn't have to take every medication for diabetes to be helped.
Right. Well, and I guess that was also, because there was kind of a pros and cons with each one, depending on, what the specifics the individual might be looking at. Is it, I guess what I'm thinking, what's the wisdom in terms of mixing and matching? Obviously, they should consult with their physician, as we should with any drugs. But,
right.
Is that a possibility here with some of these that we take maybe some of this and some of that?
Oh, absolutely. Absolutely. The two that really work well together are the SGLT2s, the ones with the initials, SGLT2s and the GLP1s. So because we're covering a lot of organs that are being helped with those two medications. We get a lot of effects on different organs. And if you add metformin to that group, now for a lot of people, we're getting some kidney protection. And I'm hesitant to talk about the SGLT2s. They're coming out with a lot of data that shows they have heart protection. All their studies are showing different kinds of heart protection, but in general, it looks like this group is really protecting the heart. So if we can use that group and protect the kidneys and the heart, and then we've got our GLP-1s, which help with weight loss and appetite, and between those three, they're all pretty specific in how they work on your sugar. So you have a really low risk of hypoglycemia. And I think that's really important in order to get people to goal. They can't be afraid of getting their sugar too low that they're going to feel bad.
Okay, very good.
So by targeting certain medications and really eliminating or lowering the risk of hypoglycemia as much as we can, I really feel strongly that is the key to getting people to goal better with their sugars, because those hypoglycemic events are awful. Nobody wants to experience those, and we tend to let our sugars run a little higher in order to prevent that.
Yeah, right. Very good. And just to clarify again, all of these that you presented on here, these are all oral medications, correct?
Well, every one of them has a oral form,
Yeah,
even the
okay.
GLP-1s. Although the GLP-1s, there's only one that is oral, and the rest are all injection.
Ah, okay.
The
Okay.
GLP-1s. I was just looking, how far down was that slide? Here.
That's a,
Not big enough for me to see them.
sorry, yes.
Oh, it was up. No, that's okay. It's here. So here we go.
GLP-1 inhibitors,
So
yeah, okay.
the Ribelsis is the only one that's a pill.
Ah, okay.
So we finally have this injection. They've been out, I think around 12 years or so, and they've always been an injection. And about a year and a half ago, Ribelsis came out in a pill. So I think that's fabulous because it's just as safe for the kidneys as the injection.
Ah, okay.
So we do have that option of actually having people with kidney disease completely staying off injections and not having to go to the insulins. Although these once a week are pretty darn tolerable. They're pretty easy to do. They have these self-injectors, and it's not like a needle in a syringe. They all come in a pre-filled pen that's super easy to use. And once a week makes life pretty easy with that one too.
Very good, okay. We did have, so Patsy was starting to ask a question, but apparently in our discussion here, we've answered it. So it's good to know. I hope that provides what you needed to know, Patsy. If anybody else has any questions, feel free to type it in right now. I would just like to remind everyone that these kidney talks will remain posted on our Facebook page at NM Kidney Foundation. So if you want to go back and review this information, you have the opportunity to do so. So feel free to visit our page and look over that. So with that, if there's any other questions, we'll be happy to try and address those now. So I'll give everyone a moment to do so. I would also just remind everyone about our webpage at nmkidney.org. We do have some resources on there as well. We have a page where you can help us in helping others who are either at risk or have kidney disease. One of the reasons we're focusing on diabetes is that in New Mexico, the past 10 years data we have indicates that about 60% of kidney disease is caused by diabetes. Another 15% is caused by hypertension. So addressing the issues of diabetes and kidney disease is one of the reasons why we've been focusing on this the past couple months in these kidney talks. So with that, we have another question here. Excuse me. Patsy says, diabetes classes are focused on nutrition. It would be helpful to address more about insulin. So perhaps I understand, Kathy, that we'll be having the pleasure of having you again next month.
Yeah.
So maybe that's something, I don't know, since you are a dietitian, perhaps some information with regards to nutrition and the whole issue of insulin and diabetes would be helpful.
So I think next time I'm going to be talking more of type 1 diabetes and insulin pump.
Yep.
Although some people can use them, but certainly a lot of people do have to use insulin when they have type 2 diabetes. And of course, diet, I like to call it, instead of diet, I like to call it carbohydrate management. So we're not eliminating carbohydrates, we're kind of utilizing them correctly, and meal timing is very important. And so we certainly could touch on that. That's a real important way to also manage diabetes. We truly can't expect the medications to do everything.
Yeah, right. Right. Yeah, it's certainly important. That's one of our focuses in the prevention of kidney disease. One of our 7Ds with regards to addressing the issue of kidney disease is has to do with nutrition. Water and drinking lots of water, and you kind of touched on that here as well with one of those medications. So, very good. Well,
Right.
Go ahead.
And one more thing, I guess I don't know how I failed to mention this, but with the SGLT2 inhibitors, that's that Invokana, Farxiga, Jardiance, Steglatro.
Yeah.
One of the ways that they protect the kidneys is they actually can also lower your blood pressure.
Ah, that's very good.
So
Yeah, okay.
we get that added benefit. Not only are they helping the kidneys by releasing the sugar instead of reabsorbing it, they're lowering blood pressure, which takes a lot of that pressure put on the kidney from that disease too.
That's good. Yeah, because as I mentioned, a significant number of individuals with kidney disease has been caused by hypertension. So that's encouraging. Very good. Well, I don't see any additional questions. So with that,
Okay.
I'll go ahead and wrap this up. Thank you very much, Kathy. This is very good, excellent, and definitely educational for me. Has expanded my understanding of the relationship here, particularly the impacts on kidneys. And I had no idea of the breadth of medications that were available, the various families and their peculiarities. So that was very interesting, and I think can be useful to anybody else who might be looking at this, and then to speak with their primary care physician with regards to addressing these issues if they have diabetes and kidney disease. So I really appreciate it. It's been excellent.
Well, thank you very much. It was completely my pleasure doing this, and I love to educate people. And like you said, hopefully this prompts, people to talk to their physician or even just have a better idea of how their medications that they're already taking work.
I think that's excellent. That's always fun when I visit my doctor. It's like you get the information from the pharmacy, and it's it's like reading an encyclopedia. It's like, well, what
Right.
what really is going on here? And I love the way you presented this. So that was very helpful. Thank you. Okay, so with that, we'll go ahead and close out, and look for us next month. We'll be sending out and posting our flyer for next month's presentation. And everyone have a wonderful evening.